The incidence of autism in the United States was about 1 in 150 individuals in 2000. And recently in 2020, a rate as high as 1 in 35 was reported. What are your thoughts about autism increasing in frequency recently in the modern era?
That's a hot area of debate for exactly the reason you stated.
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is my friend Dr. David Beversdorf. Welcome to the show, David.
Welcome, glad to be here.
It's really nice to see you, David. David is very busy, but he has found time amongst his international travels and multiple responsibilities to spend some time with us. David is an incredibly accomplished physician. You could call him a physician scientist and researcher. He's board certified in both neurology and cognitive and behavioral neurology. He is a triple professor of radiology, neurology, and psychological sciences here at the University of Missouri. He sits in the endowed chair from William and Nancy Thompson at the Thompson Center, which is a major resource and area for treatment and research into the condition of autism. And today, David, I'd like to talk about autism and learn as much as we can about this very interesting condition.
Glad to do so.
Excellent. Now, I believe the term autism was coined in 1911 by Dr. Blailer, and it comes from the word autos, which is Greek for self. And he noticed that some people were withdrawn into themselves and came up with the term autism. Individuals with autism symptoms, I believe, have some difficulties with verbal communication. They sometimes have specialized behaviors, some interesting reactions to social situations, and I look forward to talking about them more with you. In 1943, a Dr. Asperger noticed there were individuals who were high functioning. And the term Asperger's came into use. I believe it's not used now, but a term autism spectrum disorder, talking about the range of conditions, now I believe contains what used to be called Asperger's. So I want to learn a lot about autism. David, can you tell me in your own words, what is autism?
Well, your definition is pretty much on spot. I would add that Leo Kanner in 1943 gave the first label of autism for autism itself, using that earlier term that was defined. And the first patient that he identified, preceding Asperger, that first patient that he identified in his case series in 1943 is still alive and was part of a documentary done very recently. Fascinating story. I got to see that very recently. The trick with autism, and one of the reasons that inspired the change to autism spectrum disorder, is certainly not one thing. And so the spectrum kind of captured that aspect of it. There are literally hundreds of identified genetic contributors that have been identified.
Hundreds?
Hundreds.
Wow.
Some of them are high penetrance genetic changes, such that an individual who has that gene is very likely to have autism or autism spectrum disorder. There are risk factor genes where there's an elevated risk of developing autism spectrum disorder. And then there are other factors that have been identified. Exposure to air pollutants of a certain type increases it to some degree. We've worked on prenatal stress as a risk factor.
When the individual's in the womb, are you saying?
That's correct.
In utero.
And there's also others that have identified earlier life stress having likely epigenetic effects to increase risk in the offspring.
Interesting. Now, epigenetics is where you don't change the actual genes or the actual codes in the DNA, but you can glom on and glom off various regulators that turn these
Right.
genes on and off.
And we haven't sorted out what those are. In fact, I'd love to collaborate with the guy who first reported that, who I spoke with at our conference in Stockholm.
In Stockholm recently.
Yeah, I spoke with him, and I would love to. We talked about maybe doing that, taking his data where he looked at the early life risk factors and trying to understand that epigenetic profile, which would be just really amazing. But the maternal antibodies to fetal brain proteins is also a risk factor. So there's a myriad of risk factors. Each of them have different biological properties that we don't fully understand how they differ. And what happens as a result is when you try say, medication that you think might help an individual on the autism spectrum, you get responses all over the map. And we don't yet have a clear idea of who responds and why. But there was a really nice article actually written by one of my former graduate students, who's a science writer, and she published it in The Atlantic, about this heterogeneity or the variability in autism. And one of the big clinical trials that failed to achieve its target as an outcome measure, there are some patients that responded really, really well. And she profiled one of these. It's a real problem now. They have this drug that is sort of not on the path to approval at this point in time. Maybe that could evolve if they could sort this issue out. But it really, really helped a handful of patients. But the overall result wasn't positive.
Yeah.
And that's a problem. That's a recurring theme in autism spectrum disorder.
Because I watched one of your videos on the internet, and you mentioned this and said that maybe there's different diseases, different genes and whatnot, and it's only a subset that'll respond to a medication. So obviously there's a lot more work to be done.
Right.
So in my field of infertility, there's a lot of talk about sperm getting worse over the years, perhaps infertility getting worse over the years. And the question is, are we just more aware of it now? Is there something called a selection bias, or is it really going up? So it's hard to sort out. Are we just looking harder for something, or is it truly increasing in incidence? Now, according to something I read, the incidence of autism in the United States was about 1 in 150 individuals in 2000. And recently, in 2020, a rate as high as 1 in 35 was reported. What are your thoughts about autism increasing in frequency recently in the modern era?
That's a hot area of debate for exactly the reason you stated. Certainly, some of the increase is accounted for by increased awareness. We now think of that very early in asking the question, gee, could this be autism spectrum disorder? We really are quite aware of that now. And somebody who might have been peculiar in the eyes of many in the past may or may not have been identified as Asperger's syndrome, may be identified now, or there may be somebody more severely impaired and said, oh, they're just incapacitated, and used whatever term was proper for that era, and that now would be recognized as this person has autism spectrum disorder. This is a case of a more significantly affected individual with autism spectrum disorder. So there is a portion of it that is that. The extent to which that is the whole story is a source of great debate. One person did report a study a few years ago suggesting that the incidence of non-autism associated developmental cognitive impairment decreased at a somewhat similar rate to the increase in diagnosis of autism spectrum disorder.
So it kind of shifted, you shifted categories perhaps.
Right, some people that were just being the old term mental retardation, it is no longer the appropriate term, these days because it has become used as a slur.
Right.
But it, it encompassed things that might later have been recognized as a more severely affected autism spectrum person.
So I think we can expect this to evolve, our understanding of this.
A fair statement.
As we have physician scientists like you and researchers all around the world looking at this, this issue. Now, is it true that men seem to get it more often than women, or boys more often than girls?
It is true. The incidence had been 4 to 5 to 1.
Uh-huh.
More recent estimates are actually a little less, because recognizing it in females is become an area of focus. And there had been a lot of females that had been missed, and we don't know where it's landing. Probably still a male predominance. Sometimes females manifest a little differently as well. But we do have a problem with the gold standard. The gold standard is a psychometric testing and clinical diagnosis pattern. So we don't have a physiological biomarker to say, oh, this person has autism. We have a lot of biomarkers that have been used and proposed, but the trick is that if you have that biomarker profile and you absolutely don't clinically have autism, you definitely don't have autism.
Okay.
And if you have autism and you don't have the biomarker profile, you still definitely have autism. So that's
interesting.
So it's not like say Huntington's disease where you have a gene.
Yeah.
Right. So
the test is almost 100%
right
accurate.
Or if you're not, you're just at greater risk. Yeah. You're still you have the gene and you're definitely getting it. Now here's the trick. We're just now beginning to develop treatments that target Huntington's disease, and we've known about that gene forever. With autism spectrum disorder, we have 200-something genes, right?
Right. And others that can be modified
right.
epigenetically. Now, if one is an adult, and you can use one of these, are there tests online that one can do to test oneself to say, hey, am I on the spectrum? And are there tests online that you can do, and what do you think about that?
Well, there are some things online that you can use, and ability to self-report is certainly a question. Are people going to underestimate their aspects, or are they going to overestimate their
overestimate?
Right, it's a trick. And so I would put some caution in that.
Okay.
And would recommend seeking evaluation. There are a handful of places around that do that. It is hard for an adult on the spectrum to get diagnosed. And it's a real thing because, as we've discussed, back in the day, that wasn't the front of everybody's on the front of everybody's mind. And
right.
So people could get missed and clearly were on the spectrum. And the trick is that there are other things that can look sort of like autism spectrum disorder that develop later in life. Severe obsessive compulsive disorder can evolve later in life. And if they have some social anxiety and other situations that evolve, the key is if it is someone on the autism spectrum, premorbid schizophrenia can actually look similar to this. There are other things that can look like this.
Yeah.
But you go back and you look at early development, and an individual on the autism spectrum was that way when they were age 4 to 5. And so that's the key. And you may not have access to that information in any way, shape, or form. So that's one of the keys on the autism spectrum. It can be tricky for an adult, but if you get that history that they really had some difficulty with hyper-focused interests and repetitive behaviors when they were young, and social communication when they were young, and they're still manifesting issues. And there's the flip side to that. You can have somebody who really did look like they were on the autism spectrum when they were young that have compensated brilliantly. And so it becomes tricky, and if you were to give them a test nowadays, They may or may not qualify on your test, but they may be struggling in a lot of very high-level things like maintaining a high level of employment uh, commensurate with their capacity because of these other issues that are just enough to be an issue for them. And so it it's tricky. I feel that you need to have a good assessment of where they are now and have some information about where they were back then in order to really get this sorted out.
Gotcha. So if you do a free test online, you get what you pay for. So proper diagnosis
right.
Needs an expert like you. So, say I'm a parent. I have a child. It comes out, everything looks good.
Right.
It's nursing, growing appropriately, meeting growth rates, and everybody says everything's fine. When might a parent get a hint that, gee, there's something different about my child? When might a parent notice that there's something unusual, perhaps?
Well, one of the things that's an active area of research is super early markers, ones that precede the usual 18 to 36 months where you begin to sort this out.
Mm-hmm.
Are there things going on at 12 months that you can really know, hey, wait a minute, this is a reliable indicator? Because some children will transiently show something that might make you worry about it, and then it resolves, and they don't do it anymore. So certainly if language is not developing, you'll want to get that evaluated regardless of whether it's for autism or for a primary language issue.
For any, and
Right.
would that be at around age 1 to 2 years? When would you suspect perhaps that there was a delay in language use?
You would know well before 2 years.
Before 2 years?
Yeah, well before 2 years. And I'm an adult specialist, so the specification of that early mark would be left, but you'd know within that first to second year time span. But for the more subtle things, an excessive interest in repetitive behaviors would be something that might make you concerned, at least to look into.
Now, what would that look like, Dave? Is that the rocking or tapping? What would a child do that's repetitive?
Anything that's super repetitive that just is not associated with an appropriate play skill. One of the classic ones is taking a toy car, instead of going round, 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 running around,
Right.
spinning the wheels on the toy, and being excessively fascinated with that aspect. It's one of the classic things.
Interesting.
And sometimes you'll see that they look oddly at something.
Huh.
But yeah, that's not terribly specific. But the other aspect is they don't want to interact with the other children. And so they're kind of happy to play by themselves, maybe do something repetitive. Those would be the things, if they're playing with the other kids and engaging in typical play with the other children, then pretty good indicator that they're not.
So let's say a parent suspects something in their child. What age would it be appropriate to go to a center, or who would one seek out? Obviously, here in Columbia, Missouri, the Thompson Center. Well, that's front and center. Let's say we don't have an autism research center. Where would you go to a primary care doctor? Do family doctors know how to screen for this?
Family doctors are getting more and more aware of this, and pediatricians definitely are getting more and more aware of this. So I think it is a very reasonable thing to go to your primary or your pediatrician and begin to ask them about this. And give them the reasons why that you're concerned. If you have, you could even show a videotape of some of the issues that may seem peculiar to you. It's sometimes helpful. And they could set up a referral. There's a broader range of centers aside from the Thompson Center now that are really starting to get involved with early diagnosis. In fact, the state supports these. It's been a really wonderful program that's been arranged that the state helps support multiple centers for early diagnosis. And then there's also programs through ECHO where the primary care can reach out and collaborate with centers in order to do that as well.
What is ECHO?
I don't know what it stands for, but it is a program by which individuals that are expert in the field work with primary care in order to help guide them in the diagnosis on a case basis.
Interesting. Now, I see that scans of the brain, perhaps MRIs, show actual measurable changes in the brain where perhaps connections to neurons that are far away are less and ones that are close by are close. So is an MRI scan of the brain part of the evaluation of someone, of a child perhaps?
To exclude other conditions usually.
Ah, right.
To make sure that there's nothing, oh shoot, this is due to a stroke, or this is due to a tumor that needs to be resected.
Right.
Once in a blue moon, there's something like that. And so sometimes it is appropriate if the neurological examination is completely normal. I think there's some debate as to whether it's a necessity. But there is a lot of research, though, on markers from an imaging standpoint. There's the decreased connectivity between distant brain regions is a reasonably reliable finding.
And you can see that on an MRI?
Not unless you do a functional MRI. You have to,
do you do functional MRIs?
I do. And I was trying to use it as a predictor of who responds well to certain therapies. And we're still doing the analysis on that.
So that involves, I guess, putting a child in an MRI tube. Do you have to sedate them so they don't move around? Or?
Well, we have tried to just use individuals that you didn't have to sedate just for safety. And also, sedation may affect your results.
Oh, right, right, of course.
Right. So, especially if you're asking to do a language task, you can't do a language task if you had to sedate them.
I see. So you need a child who's cooperative. Say, hey, you're going to be in this thing for a little while. It's not going to hurt. Now, when you say functional, do you inject some kind of tracer or some kind of sugar or fluoride or any fluorine?
So no injections are involved with this at all. The MRI, there's a certain pulse sequence in the MRI that is sensitive to blood oxygen levels.
Ah, so you're using oxygen in situ.
So you can, for a task-based one, you can do a comparison between that bold signal during task and during rest, and see what. And they did a lot of mapping studies and didn't find a whole lot that was different aside from obviously facial recognition areas not lighting up in an individual in the autism spectrum, and a few things that would be very predictable. Ah,
so that's very. Let's make sure I understood what you just said. You can see the visual. I guess the occipital lobe. You can see recognition areas, and they don't light up as much. They're not as active.
It's actually the inferior area where the temporal and the occipital lobes meet.
Okay.
That's where it is. And they don't activate the same in an individual with the autism spectrum. There are a few things like that that are true, but they're very specialized, and they're kind of not surprising given what you're dealing with and that they're not going to have typical processing of that information. But overall, one thing they found out was during language tasks and problem-solving tasks, distant brain regions, the correlation between those activation patterns across those brain regions was less on an individual with the autism spectrum. However, you find a lot of variability in that. You also find that if you look at different types of brain regions, the results get more chaotic. And also, they've looked at resting patterns in individuals on the autism spectrum. So do those brain areas just co-increase and decrease together? Which areas do increase and decrease? And the patterns are fairly complex and certainly wouldn't lead you to feel confident about a diagnosis based upon that in any way, shape, or form. There was some interesting research recently done that showed that infants that were at high risk who had increased extra outside the brain cerebrospinal fluid
Huh.
observed were at increased risk for developing autism. Now, the question is that something to do with the spinal fluid, or was that more with a relative lack of filling capacity of the
Right.
brain matter itself? So that there's a lot to be sorted out with that. But everybody is working hard to try to find early markers to see who we should key on for early intervention. That's an ongoing area of work.
I'd like to explore that a little more. So let's talk about the various degrees of autism on the spectrum. First, I'd like to talk about the one that captured a lot of attention. Most people are too young to remember the movie Rain Man.
Yep.
One of the main characters was an individual who many would call a savant. He had difficulties communicating in social situations, but he could count cards. And
Yep.
he was really, really brilliant. And just recently, Elon Musk was on Saturday Night Live, and he announced himself that he has Asperger's.
Mm-hmm.
It's not clear whether he's been truly diagnosed or not, or
Yeah.
he's self-diagnosed or whatnot. But
I have no knowledge of that status.
but it's certainly fascinating that an individual, and you see it with blind people, their sense of, how many blind musicians can you name? Stevie Wonder, Ray Charles, you can go down the list, where they don't have sight, but their music has compensated. Tactile, so other areas of the brain compensate. So, there's all this fascination with the savants who are incredibly brilliant in some ways as maybe a compensation. So is this a real thing?
It is a real thing, and it is not rare, but it is not incredibly common either.
Mm-hmm.
And there's a little bit of a sad aspect to it in that I think when you encounter an individual on the spectrum, you're expecting some magical skill to be present that may not be present.
Okay.
And so it's a little unfair to those folks to expect, oh, wow, what's your amazing skill?
Right. Why aren't you the richest man in the world?
Right. Or why aren't you able to calculate this amazing stuff? Right.
Right.
And some of them are terrible at math in school, and it's just the variation.
So you don't have to have a superpower.
You do not. Although there is a tendency for good reliability and certain other things that are more core traits in these individuals that one could certainly harness in helping them get jobs. But unfortunately, they have an incredibly high rate of underemployment or unemployment.
Sure.
Because it's very challenging for them to get a job. Difficulty with the interview process, of course, is huge.
Right.
And holding a job because they seem strange to their colleagues if their colleagues aren't very understanding, and occasionally some atypical behavior gets in the way.
Right. So it can be a disability. So let's say we have a child now, they're getting a little older. They've been to see a competent physician or psychologist or a team who's diagnosed autism. Is it graded in severity? I'll tell you, when I was a medical student in New Jersey, there was a psychology center there where they were studying autism, and I remember seeing this young boy, he must have been 8 years old, and his father through one of these one-way mirrors, they're in the room, and we're medical students with our short coats in the other room. And this poor little boy was just shrieking, uncontrollably, agitated and shrieking the entire time. And the poor father, you could see, was just 8 years of this. The poor guy doing his best. And they had a little trick. They had the young man count backwards from 300. So I remember sitting there listening to count backwards from 300, and we got down to 0. He was a little more calm, and he could speak and at least get some kind of check-in. but I'll just never forget seeing how difficult a severe case of autism could be. So could you talk to me about the degrees from, we've already talked about, mild, might just seem a little quirky, have an interesting personality, all the way to the severe case that I just described. Can you tell me how, from mild to severe, what type of things you'd see in these individuals?
Well, it's all over the map, and I think you're getting a good point. And there's a saying that if you've met one person, if you've seen one patient with autism, you've seen one patient with
You've
autism.
seen one person. Gotcha.
Right, so,
gotcha.
And I think, but you highlight a really important point. A lot of the conversation is on taking the individual who is relatively well-functioning and finding ways to support them getting through college, getting employment, optimizing functional independence and quality of life, which is great. And I am 130%
Right.
on board with maximizing all of that. But often it gets lost in the conversation, the also very significant number of individuals who have really no capacity for any of that.
Yeah, they're really severe.
Or even enough severe that they can't really hold a job or be functionally independent and will always need some kind of support or a lot of support or a ton of support.
Right.
So there are all kinds of different levels. There's ones where they can do pretty well on their own, and I've known a number of these individuals. In fact, I've known some, I know them very well actually, who were amazingly successful individuals, full stop. They're just successful. And the most you could say about them is they're quirky.
Right.
But they're completely successful individuals in every measure you can imagine. And then there's some that need a little support to get there and will get there. There are some that can handle certain aspects of their life, but not others. Some never understand the value of money. There are some for which driving might be risky because they can't contextualize very well.
That's a real world issue.
Right, sure. But that's not but you don't want to downgrade somebody because they have the diagnosis, because a lot of them can do that absolutely fine.
Sure.
And there are some that, that one of the issues is individuals on the spectrum, at least a fair chunk of them can be misled and there's the story that inspired the movie The Accountant is actually based upon a real person.
Would you tell me more about that, please?
This real person, and he's written about this, so it's public information, was a mathematically brilliant guy on the autism spectrum. And an unscrupulous, criminal group got him to do their finances. And when it went awry, they tried to leave him holding the bag, so to speak. And his family was able to get him out of that situation. But you don't read other people's intentions. That's one of the core features on the autism spectrum. So people get taken by swindlers or bad actors without being on the autism spectrum.
Sure, the elderly are getting taken advantage of nowadays.
Absolutely.
Oh, my goodness.
I see that all the time as well. But individuals on the spectrum can be as well.
Wow.
And so there are a lot of aspects. And then the more severe ones that have, can't, you name it, they can't do it. And they will need care in a compassionate setting that allows them to at least function to the level they can and have some quality of life. And we don't have a good system for that.
Are there, I know, I'm totally ignorant about this. I know there's assisted living for individuals with dementia and Alzheimer's and memory wards or all that kind of stuff. Is there anything analogous to that for individuals with autism?
Well, there's independent supported living if they have a certain amount of skills they can manage on their own. Um, and so they need somebody that comes in and helps them on a very regular basis or even a continuous basis. There's group homes, uh, but the worrisome is that it varies widely, the quality of these, and
Sure.
you don't want somebody that you love and care for to be stuck in a horrible situation,
Right.
where they're just living a life that is incredibly, unsatisfactory by any measure.
Yeah.
Um,
Yeah. I know it depends house by house, who
Yep.
manages it, how much staffing do they
and
have.
that can turn over.
Yeah, and they turn over.
Yep.
Yeah. So
So
it takes a toll.
yeah, it's a huge concern, and so having some system in place by which you have systems are good would be a wonderful thing, and that's a challenge.
To challenge. So, like many diseases, let's say diabetes, you can give insulin, it fixes the problem for the most part, and you go on. Let's talk about the various treatments one can have. Now, you've already said, well, it may be a whole range of different conditions, so insulin may not be right for the non-diabetic with similar symptoms. What type of treatments, David, are available? Let's say you have let's say a child now. We've talked about family support and other social support and caregivers and whatnot. What other treatments are available, David? And what is maybe on the horizon? What are you working on in your research?
So, still the best tool we have is early behavioral intervention.
What is that?
It's where you have these behavior analysts, specialists that try to help facilitate more typical behavior.
So teaching, guidance.
But very high intensity and not like typical teaching, more behavior modification kind of teaching. So it wouldn't be, hey, here's how you add and subtract, because you're trying to get them to a place where they can follow your lead to do things like add and subtract. And it's a long process. It takes a lot of training to get people ready to do that, and of course a lot of training to do it. And that's still the best tool we have to help individuals.
If you start early, does that help?
The earlier the better.
Okay.
And it's more for it's typically for the ones that are showing really clear signs that, hey, I mean, if somebody is just a tiny bit quirky and they're going to function just well, it's less of a concern. But for the ones that really have pretty significant adaptive behavior issues that they would need work on, those are the ones that definitely would benefit from it. There's variability in who responds to that. So that's still the best tool. And on the pharmacological side, we're still, it's a big push, but we don't have anything that matches that.
So there's no drug for the particular brain problem. It's like not a pill or a shot that's going to make more connections where you'd want them or make fewer. So you can't address.
At this point, no, but there are 2 drugs that are FDA approved for autism, but they are for autism with behavior disturbances.
Okay.
And they are atypical antipsychotic medications, which is kind of unsurprising. The behavioral disturbances and the aggression that comes is improved by these.
So you could treat aggression with
clearly.
an atypical antipsychotic medicine.
Right, but then you have to monitor for the risks of those, for your sugars and your lipids.
So there are side effects.
Oh yeah, there are risks at least, and weight gain and things like that.
Oh boy. Now, I know that agitation, obsessive compulsive type behaviors are part of this. Are there medications that will treat just those symptoms?
You can target the various symptoms that arise reasonably as you would in another person that has those same issues. So you can target obsessiveness in the same manner you would try to target it in a patient with obsessive compulsive disorder. There's an incredibly high incidence of anxiety. You can do the same for that. Some of the higher functioning ones that are struggling to fit in sometimes have depression. And so you can target that as well.
So a typical
Right.
anti-serotonin uptake inhibitor,
You could do those.
one of those that can be used.
They don't help autism itself, but they could. The response is kind of a mixed bag, and we don't always have good data. We usually don't have good data within autism itself, but you could certainly attempt those things, and it's not an unreasonable thing to do. ADHD symptoms are also not uncommon.
So you could use one of these mild stimulants for ADHD, and it'll help
Right.
focus?
It helps focus. It focuses the issue. It won't help the autism, but it'll help the focus. We did a clinical trial with propranolol, the test anxiety drug.
Propranolol, just so everybody knows, is an old drug. It's a beta blocker. It slows down the heart. It also lowers adrenaline. It's used for stage fright, tremors. It can be used for a lot of things, including anxiety.
And we actually have a clinical trial that suggests that it may benefit anxiety on the autism spectrum. We're hoping to do a larger follow-up because that wasn't our primary outcome measure. Our primary outcome measure is hoping it would improve socialization via probably the anxiety mechanism, but we didn't get a good signal on the socialization. But we did have a signal on one of our 2 measures of anxiety. So that deserves follow-up at least. So there are a lot of things, but as far as the autism core issues, the social communication issues, we don't have anything to add to the picture yet, although a lot of medications have been tried. Phase 2 to 3 trials, not a single one has hit the target yet.
So you go to these conferences around the world, David. I'm sure you see posters, and the reason you go to a conference so you can chat with somebody from South Africa, then someone from Taiwan, and then somebody from Scandinavia, Argentina. You can pull a country from all around the world. We go to these international conferences, and we chat, and we learn from each other. Anything on the horizon? Is anything exciting that when you were in Stockholm? Any scuttlebutt at the bar? Did you, after a couple drinks, did somebody get excited about some early research that might not have hit hit the Google yet?
Well, there's a couple of things worthy of mention. Of course, one really is a follow-up of our earlier topic, that we're really trying to get teams together to sort of tackle this issue of the heterogeneity, the high degree of variability, such that you can target one subtype and be able to get a better outcome. A lot of people are doing that with specific genetic subtypes. The question is, how translatable are these to the other patients?
So let me stop right there. So you're telling me there are, I guess, a blood test or a cheek swab or some kind of test that people are using to define and classify these various subtypes of autism? Am I hearing this correctly?
Not yet, but that's being worked on.
Okay, so that's exciting.
Yeah.
So rather than treating this as one condition with degrees of severity,
Right.
maybe there are different clusters.
And it makes sense if you think about
Sure,
it.
okay.
Because one of the proposed measures was the research domain criteria way of assessing things, as proposed by the National Institute of Mental Health, is where you categorize by severity on a symptom. So repetitive behavior severity. Now, the weakness with that is you could have somebody with this degree of repetitive behavior difficulty due to this gene, and another one with this degree of repetitive behavior due to a completely different gene.
Oh, it's not a one-to-one at all.
Right, so you may be, if you develop a drug targeting one of those genes, you may get a great response, and the other one not so much. So that getting a biologically based subtyping is key. And there are a lot of people doing a lot of work on it. There's one other thing that my colleague Shirin Chu and his student Will Baskett here at University of Missouri, we did a big data scoop, and Dr. Shu is really good at that. Big data exploration.
Computational biology.
Yep.
A whole
exactly.
world. Big
Yeah.
sets, big data, big computers.
We looked at the Spark data, which is 50,000 strong individuals on the autism spectrum and family members of them.
And you have genetic information on these 50,000.
All of them.
Fascinating.
So we looked to see, he has some new computational approaches to this. And Will, the student, said, hey, would it be good for us to look at protective genes? And I had the wisdom to say, yeah. and
Protective genes.
Right. So if you have that
That's
big of
right.
a data set, you could do that. And so there are some.
Why do we not get autism?
Exactly.
Right.
Why does one sibling get it and the other? So we're going to be following that lead and trying to understand what it is about that gene, the why, the how, and to start chasing down that tree.
Well, it's true in cancer, David. When
Right.
you lose an inhibitor,
Right.
then you get the growth. So it's the protective gene, defect in the protective gene that results in that type of
And that
disease.
really hasn't been dug into.
Oh, that sounds very fertile
Yeah.
ground to be researched.
We're all pretty stoked to be diving into this area.
Because then if you find problems, then you can. It's actually a target for treatment.
Right.
Fascinating. Any other scuttlebutt in Stockholm, David, that you heard in as far as diagnosis or treatment or exciting new research? Anything else come to mind?
One thing that was heavily emphasized in one panel was the problem with trials. And there are people that do open label studies, which you just give a small group of individuals the drug.
That's when it's not blinded, so people
Yep.
at home understand this. That's when the doctors know what's being given, the patients know it's on the bottle. Frequently with scientific studies, you've got two bottles, A and B, or blue and red, and you don't know which one's the placebo and which one's the active. So the open label, you're not having the blinding, as it's called.
Exactly. And so sometimes they do that as a proof of principle or feasibility, but then people take that and interpret it as a success if there's a positive response. Here's the trick. That can be incredibly misleading.
Right.
And the reason why is I can vouch for this. Our placebo group in our propranolol trial looked great. So you actually have to have your treatment group look even better.
Even better.
Right. So
right.
And you could I would absolutely bet that if you design, and there's also a time course on autism, especially if they're getting those behavioral interventions, of improvement in many cases. And so on average, you're going to have some improvement, especially if you track people on long enough.
Sure. They're going to your place, they're getting love and attention and care, and that's good for everything.
The targeted therapies and the families getting better services. And
sure.
So that was really highlighted as a huge issue. I will have to confess that the time zone jet lag adaptation affected the entire first day of my conference.
These heads of state, they get in their planes and fly around the world and have to look good at 2 a.m.
It's easier, I think, if you have your own jet.
Air Force One helps a bit.
So you're on bed, you can pop out and don't have to strap into the seat that doesn't fit you.
Correct.
So there's a lot of potential for growth in the field. And there's a lot of synergy. There's a consortium in Canada that has done some really cool work trying to look at multiple mouse models of autism, taking the specific genes that we know cause it and compare them to the human setting.
So this is exciting. Let me also explain this to the audience. Having an animal model for diseases can sometimes be incredibly important. Like studying diabetes. I remember this is an old one.
Mm-hmm.
You take mice, you give them streptozotocin, and it kills their insulin cells. Now you have a type 1 diabetic mouse, you can do studies. It gets much more sophisticated when you can knock out genes. Mm-hmm. You know what gene's important, you can literally knock it out in an animal and then see what you can do to get around it. So there are models for autism. That's very exciting to the science part of my brain, David.
So they don't call them an autistic mouse because it's a human clinical syndrome defined by human behaviors. But what you can do is that there's actually one of the more straightforward things they do now is a knock-in. Mm. So they take the human gene that is associated with autism and insert that. So you get to see, okay, you get to measure what it's doing to the brain in a way you can't do with a person.
Sure.
You get to measure what it's doing to the physiology in a way you can't do with a person. And you can give that mouse a drug to see how it's reversing that in a way you can't do with a person. And then if that drug is known to be safe, then you have the ability, this is a very scaled down version of it, but this gives the impetus for doing a trial to see if that drug helps. And this pipeline is far from 100% effective. You have a lot of things that tank as they make this transition from A to B to C.
Sure.
And
there's species different, and mouse is not a human.
Yeah, so there's a lot to be done there, but you can begin. You can begin to get a clue as to what the targets are that you may want to get at. And my area that I like is repurposed drugs, so that you can use something you already know is safe.
Right.
In people. And you could target that individual pathway with a novel drug, but that'll take a long time to get safety tested. If you have something that already exists that targets that pathway, then that could be a real benefit on shorter order.
Sure, it lowers the barrier to entry.
Right.
And I'll explain something else to our audience. If you have a completely new drug, you've got to start out with animal studies and what are called phase 1 trials. You give it to healthy people, and you just see how long it lasts.
Right.
You just look at levels. You're not even looking to see
the toleration.
How do they tolerate it? And then phase 2, you're saying, well, is it safe? Do they tolerate it? And it's these later studies where you're testing, does it work?
Yep.
And then later, after it's released, phase 4, do you still see benefits? So it takes a long time, very expensive. But if you've got a drug that's already on the market that you can repurpose,
right,
you can already start testing it.
So the group in Canada, what they did was they now have 150 different mouse models, one of which is our prenatal stress model, I'll proudly say. And they have done comparative brain imaging studies to see, okay, which groups of these genes have a similar anatomical pattern in the brain. And which is a great proof of principle to show that there are clusterable subtypes that have some common physiology. Now, it doesn't get you to treatment, but they're beginning to look at questions about pathways now, which is really the key. Because it'd be great to know that if you develop a particular medication that helps this subtype, what other groups are more likely to respond? And it's just a fantastic thing to know the answer to. But there's another layer to that. In most patients with autism, we don't have one of those genes. It's a minority of them that have one of those genes. In most cases, we don't know what it is that's causing it. So there are all kinds of other questions. That's where your biomarker profiles become intriguing, although we don't have the answer to that. Are there gene expression profiles? Are there protein profiles? Are there physiological profiles? Well, there's something else to give you a clue as to which individuals are going to cluster together in a particular way for treatment. The low-hanging fruit for us is for the propranolol one. We've looked at arousal with heart rate variability, and things like that to see if we can predict. We're still running the analysis on it to see if we can predict who is the best responders on that trial. Kind of a low-hanging fruit. It's kind of obvious that the more aroused, more likely to be the ones who respond better. There's one of the drugs that failed in its phase 3 study was the dementia drug memantine.
Used for Alzheimer's.
Yep, exactly.
Memantine,
Because there's a lot of data suggesting there's an excitatory to inhibitory imbalance in autism. Too much excitatory activity in proportion to its inhibitory activity. So two of the big trials that were done, one was to increase that inhibitory, one was to squelch that excitatory. So memantine was the one to squelch the excitatory. And the clinical trials run by the pharmaceutical company came out negative for their primary outcome measure. But there are a lot of other investigators that have looked at this as well, and suggesting that some patients respond well to it. Now, I also treat Alzheimer's disease, so I'm really comfortable with this drug. So people that were like desperate to try something new, I'd say, look, I've seen some papers on this thing prior to that trial coming out. We could try this if you guys want to, knowing that we're not, anticipating. Some people respond, some don't. We have no idea who they are, and so we're hoping to do a trial. We did a pilot trial of this and had some limited results based really due to the very small sample. To try it, you can measure glutamate in the brain with MRI using spectroscopy, MR spectroscopy.
Oh, I didn't even know that existed. Okay.
Yeah. There are certain chemicals you can measure. Glutamate just happens to be one of them.
Okay.
And so we were hoping that if you're giving a glutamate blocker, maybe the ones with the greater glutamate activity are the better responders. Now, the small pilot sample was equivocal on that, but there's enough. You could at least run a calculation to say how many we would need to predict it if this pattern holds. So that's the kind of things I think could hold fruit, at least in the shorter term, when we try to get bigger picture answers in order to subtype individuals and in a way that helps us develop new treatments.
So what I'm hearing here, David, is cautious optimism that progress can be made.
Progress can be made. I think that's a good. That's the level where I'm at. Cautious optimism, and I really think progress will be made. The question is how broadly that will be applicable. I think at some point we're going to have certain subtypes that we can help those individuals to a fair degree, and other subtypes where it's going to be trickier. We kind of know that's the case anyway because but we'll be able to hopefully identify who they are and say, hey, your profile fits something that might respond to this particular treatment, and so begin to approach it that way. And hopefully, and it's a lot of conditions. There's a good analogy with cancer. You can't you can't expect everybody to respond to the same different chemotherapeutics for everything. So, and even within a specific type of cancer, like breast cancer, we have these hormone receptor assays that tell us what kind of approaches are best. And then now you get the antibody therapies targeting melanoma. It was absolutely mind-blowing that our former president, Carter, was diagnosed with melanoma of the brain years ago, which at that
fatal, rapidly fatal in the old days.
Absolutely, I mean, just
devastating.
You give people a ton of steroids to decrease the swelling and tell them to get your affairs in order. That's the level it was at, and you had weeks to months at very short time, but his happened to be antibody sensitive, and he's still alive. He's in hospice now because I think it has recurred, but or something has happened. It's never been made very clear as to what the new diagnosis was, but that's been years, and it's astounding. So targeted therapy is for real, and it's playing a major role in things like cancer. Hopefully we can get enough of an understanding to be able to bring that to the table on the autism spectrum.
Well, I'm learning so much here, David. Now, Dr. Gill podcast will end without some controversy. So I'm going to put you on the spot about a couple of things. If you don't have data, maybe just give me your opinion on this. I'm going to talk about two things. One, is autism worsening or exacerbated by modernity, meaning the modern world, the modern diets, the modern life, the modern toxins, whatever is new about our life nowadays? Clearly, this is true with obesity, and all that. That's just a good one as an example. Do you think there's anything about the modern life anywhere that is increasing the incidence of autism?
It's not inconceivable. I'm not sure it accounts for the whole story, but we do know that certain air pollutants do increase the risk.
Really, there's a measurable statistical association.
Very replicable.
Really?
Very replicable. And multiple studies have shown this. It's a risk factor. It's not, if you're living with exposure to that, you're going to have a child with autism. And there's a researcher I met who's really sharp, who's done the interaction between stress exposure during pregnancy and the air pollutants. Is really interesting. Yeah, so the interaction between factors is important. There is some evidence that diet could be important, although that's evolving. There was one study that showed that people with a really, really bad omega-6 to omega-3 ratio in the diet maternally are in greater risk, have children with greater risk, and various cardiovascular risk factors seem to have some relation to the risk as well. These are all relative issues. And so it is not inconceivable that there's something there. It may not be enough to tell the whole story, though, but there could be some issues that are modifiable in that regard.
And certainly, if you look at severely premature infants, the viability, the age of viability keeps going down, and they're much more successful at keeping severely premature infants alive, and that certainly is associated with modernity.
Certainly.
The modern world. So is it true that premature infants are higher risk of autism?
The data does support that. Yes, there is that. Although I will say that reproductive assistance does not appear to be.
Yeah, IVF. So doing thank you, thank you. Let's announce this to the world, scream this to the world. I do IVF.
I've looked at that data, and that one looks to be
that's pretty clean. Yeah. Although they're very interesting epigenetic changes, and this is beyond the
there could topic. Be epigenetic changes, but they don't point in that direction apparently.
Fantastic. Now, I have heard that perhaps. Now, we have a large Amish population here in Missouri. The Amish many of them don't use electricity, horses and buggies, no pesticides, a more simple, more traditional way of life. Do you happen to know if the Amish or the Mennonites on the farms have less autism? Is that?
I do not know the data in the Amish. I do not know the data. It's an interesting question because you could also, if there's a genetic preload, they could have an increased risk.
More, yes, and they have, in fact, because there's less genetic mixing, they have more of certain conditions.
Right.
Yes, so it's not clean. It's not. Yeah. It's not that the only variable is modernity. There is a genetic issue is co-present.
There was a report that appeared in one of the conference posters. You walk through the posters, and every now and then you see one, you go, what?
Right. I love walking posters.
And it was by a prominent guy, and it said that there were no documented cases of autism spectrum in a substantial Inuit community he examined.
Inuit, that we used to call Eskimo, so natives in the north.
In the north, like northeastern Canada.
Okay.
I can't remember. It was Ontario, I think. But I'd always wondered about that, and it never came out as a paper. So in Stockholm, the guy from that poster 15 years ago, poster was next to mine.
Oh, how fortuitous.
And he's a well-known guy that I just never happened to meet. And so I just sat down and said, I've been meaning to meet you for 15 years.
Perfect. An angel moment. There he was.
And as I started, I said, what happened to that data? And he said, well, it never really got written up, but what the inspiration was, and it speaks to this a little bit, there were two communities. One was the Inuit that had the traditional high fat, but it was all like seal blubber and all that.
Yeah, I'm very pro-fat. That'll be another podcast. Fat's good for you.
But yeah, but if it's the right fat, right?
Right, sure.
And so, and then the other indigenous people that lived in the same area that were not of Inuit origin, which could be a genetic factor as well.
Okay.
But had more of a fast food kind of diet.
The seed oils, yeah, the omega-6s, etc.
Exactly. And the incidence of autism was dramatically different between the two groups. And the native people that were not of Inuit origin and Inuit diet had a much higher incidence. And so I was like, man, it'd be great if that ever got written up. And it's at this point archival data, so who knows if it will be. But it, gosh darn, was a poster at a meeting. And I was curious. Oh yeah, no, that didn't pan out in a further study. No, that's not what he said. he said, it was not of enough sample or something to get out there. But,
and people have to take interest in these things. You have to take time out of your life to get the data, crunch the data.
Yeah, and that may have been an issue where they didn't have the opportunity to polish it to be a paper.
Sure.
So, but that was one of those fortuitous things at that meeting why they're so gosh darn valuable. And I'll tell you, the other thing for my graduate students, it's a networking opportunity.
Oh yes.
Yeah, I mean I had one that was wonderful guy, Korean, Taeson Woo. He's COVID hit just as he was getting ready to network, and I was like, dude. So we were able to. He's got himself a fantastic fellowship. He's starting this fall. So he's set. He's good to go. But I was like petrified. It's like, man, how the heck? How are we going to pull this off? It turns out a colleague of mine who I knew very well, who's phenomenal, just happened to get recruited away to a high-profile position and said, I need 3 new postdocs.
I need a postdoc. Well, there you go.
I got one. He's awesome. He needs to play. And so it worked out perfectly. But I advocate like hell for these guys. And this guy deserved it as much as anybody. But that's the point of these conferences is you get that handshake between two people.
Sure.
Yeah.
Behind the scenes is where stuff happens.
Yeah.
So maybe we can end on the final super controversial topic. Do vaccines cause autism? Now, my understanding is there was a paper, and I think it was on the MMR vaccine. Now, please tell me if I'm wrong.
It was.
And it was completely fabricated. It was by a zealot. The paper has been retracted. I think the guy lost his academic position. But what is there data, or do you have any opinions, David, on perhaps the number of vaccines we get? Maybe not a particular single vaccine, but could another thing of the modern world, could it be a number or the load of vaccines could somehow be associated with autism?
Well, the story you indicate is accurate. It was a cherry-picked thing.
Tell me more, please.
So what it was is he just picked cases where there was autism and there were vaccines, and literally every author on that paper has disavowed that paper except for that one guy.
Okay.
So that's telling.
That's why we have randomized studies. If you cherry pick, you're introducing selection bias, and the results are generally not valid.
Right, and so there have been multiple epidemiological studies that do not support an association between vaccines and autism. It's not something and I've spoken to experts in the field.
Okay.
It's not my area of expertise,
Okay.
but I've spoken to expertise in the field that say this is a sealed issue.
Okay, so you have spoken, this is important, Dave,
Yeah.
because you run in these circles. You
Right.
talk with experts in these subtopics.
Right.
And you've talked to people who have looked at these big data sets,
Right.
smart people you trust,
Mm-hmm.
and they have seen no signal, it was called no signal, no indication that vaccines, and does this include the number of vaccines as well? Or is it vaccines in general? Do you
Vaccines
recall?
in general, I can't specify whether there's a. I think the number has been looked at, but
Okay.
it's just not. It's not something if one is to become the defender on this issue, it consumes a lot of their time because there are people that kind of live in a fact fluid zone and
Right.
spew things.
It's a nice way to put it.
Yeah, I remember one guy was being interviewed and he was spouting spouting off his opinions and conspiracies about that, and I heard him misquoting papers
Okay.
that I've actually reviewed.
Okay.
On I know the people that do the maternal antibody fetal brain, and he was like citing those as if it was evidence for the vaccine. It's like,
No.
no, it has nothing to do with the vaccines.
Okay.
There are immune factors that have relevance to autism, but that's not, those are different. And so it's a challenging topic because you just get people that are hot-headed on the topic, and you can't dissuade them of anything.
They have agendas.
Yeah,
So, and I want to put an additional fine point on this. Most, I dare say all, but these researchers, if there's a signal, they're going to tell you. They're going to say. I don't think they have an axe to grind. If there's a problem, I think they'd be the first people to say, hey, we got a vaccine problem. Maybe we, modify what we're doing, take other things into account.
Right.
So I would hope that these are independent, well-meaning arbiters, these epidemiologists and people that crunch these numbers. And I think if there was a signal, I don't think there's any conspiracy to hide this. I think they'd be the first people to be waving the flag. Hey, we got a problem here, folks.
Right. One thing that's unfortunate, at least in other things, they're unreliable sources that become very, 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 very vocal, can sometimes undermine a field for undermine their own interest because of their activity. We've seen this before. There's something called facilitated communication, and there are people that did really unscrupulous things, and where you had people looking, typing to communicate, but you'd help them type. And by facilitating them, right? These individuals, their families were the family. It got a little bit of press early on, and there was supposed studies that came out, and then a couple things happened. Number one, there were a few cases, and this is horrifying, where somebody was, the family was suspicious that, hey, there's nothing coming of this. And the facilitator person that was working with them began to have the patient typing up accusations of abuse by the parents.
Oh.
And, and so and then they did blinded studies of those things where the facilitator saw one thing and the person with autism saw another thing, and whatever was typed was what the facilitator saw, not what the individual autism saw.
Gotcha.
And what the problem is that there are some patients that do better with other forms of communication, and that research was delayed because of the reaction against this, where you had unreliable actors. And I think that's a sad thing in the sciences, that does occur. And so you can actually, so the irony is that these people, if there's some little tiny hidden important message to be going on, they have destroyed their own capacity for doing that by creating such a huge barrier, and by not being good faith actors. If there was some important message like that, maybe that's not the case, but something else that we need to watch out for, it's going to be harder to get a hold of that because of their because a lot of people have acted in very bad faith. I actually know somebody who published a paper on the topic, and she got messages saying that with a picture of her license plate, so you know where you are.
We know where you are.
We're going to come after you and all that stuff. So it's that you get that kind of action going on, and it actually undermines the science. And now, research on heavy metals is now kind of difficult to look at now because, oh geez, is this coming from that space? And so it's a sad thing, and there is, and also so science does have major paradigm shifts are tough in science.
Yes,
like the Heliobacter guy.
Right. Yeah.
How long did it take him to get that?
Right. Just tell everybody the story. This guy said that we always thought it was always said that ulcers were due to stress,
which may still have a factor, but
right. And he said, I'm finding these Heliobacters, so no one would believe him, so he inoculated himself with Heliobacter and got an ulcer. He had to be his own guinea pig.
Yeah.
Right?
You think that died in the 1700s, but no, that the Pasteur days, right?
Yeah, right.
But so paradigm shifts are tough, but the sad thing is individuals like this have inoculated the field to make little other stories that might be important hard to even detect.
Gotcha.
Because of that. So they undermine their own interests, which is unfortunate.
Well, David, I am so pleased that there are well-meaning, intelligent, wonderful people researching this field of autism. I have learned so much from you. You're a wonderful part of our community, the Thompson Center. I appreciate all the work you do. And once again, thank you so much for your time and coming to be with us today.
Appreciate it. I want to give a shout out to the folks at the Thompson Center as well. And
any people you would like to acknowledge?
Well, Steve Scheinkoff, he's executive director. He's a wonderful collaborator as well. The research core, led by Nicole Takahashi, is absolutely phenomenal. And overall, the whole group is fantastic. Department of Radiology and Neurology and Psychological Sciences, with whom I am very heavily affiliated. I'm also the director of graduate studies for the neuroscience program. We've got some phenomenal people getting involved in the neuroscience research as well.
Fantastic. We'll put a link to the Thompson Center at the description below.
Fantastic.
David, thank you so much.
Sure thing. Take care.